So today in this video, I'll be showing you the basic concepts of multiple skull base defects. Now this patient is a middle-aged male patient with the history of transcranial approach done twice to repair the CSF leak. Now this patient had a road traffic accident, a very serious one, following which he had nasal rhinorrhea, which was confirmed to be as CSF from the right side. This patient was operated twice transcranially. You can see over here, this is the cranium. Now, following the RTA, there was definitely some kind of skull base fractures. This was done 10 years back. Okay, the first episode, the first intervention was done 10 years back. That's a lot of time, right? And the second surgery was done, I think, in a span of a year or two. And then the patient has come now since quite some time, since 6 months to 8 months, roughly a year max to max. The patient is not exactly aware of the duration, but max to max within a year from today, this phase, the patient was having again recurrent episodes of meningitis, headaches. The patient was not doing well, and repeated scans were done to evaluate the case condition, and the diagnosis was made the patient was having a lot of recurrent nasal fluid rhinorrhea from the right side, which was confirmed to be as the CSF. So the patient was referred to us, and we as a team, neurosurgeons and the skull base surgeons, we decided what to do for the patient. So I'm going to show you the basic CT scan. So I went through the CT scan in detail along with the MRI, and to be really honest, you can see on the screen there, this is quite a complex picture. You can see on the CT scan, quite an abnormal view, not the routine one as per sure. So you can see I'm going to go from the very front to the very posterior aspect. I'm going to show the CT scan. At the same time, I'll be discussing the history as well. So this is a coronal view. Always ask for a 0.1, not exactly 0.1, but 0.5 mm CT scan. That's the best you can ask for. Earlier, we used to consider 1 mm as the best, but then as the trend goes by, as the deeper we go into the study of CT scans, we come to know that 0.5 today is the best scan we can ever ask for to the radiologist to evaluate each and every neurovascular structure. So this particular scan is 0.5 mm thickness, which is the ideal scan, I would say, better than the 1 mm scan. So I'm going to show you this. So you can see as I'm going to the very anterior part, that's the frontal sinus on both sides. See, the frontal skin looks normal. That's the nasal bone. That's the septum, looks normal. As you keep going behind, you can see that's the frontal bone, the sinus on the right and the left. You can see certain amount of collection in the left side frontal sinus. This could be mucosal hypertrophy or some kind of polypoidal change or some kind of fluid. Due to the positional change, it is appearing as like this. So it's definitely not a mass. The patient has no history on the left side for the nasal rhinorrhea or CSF leak. It's constantly from the patient's right side. So you need to focus on the right, but at the same time, you need to see on the left as well. So far on the right, you can see some kind of changes in the bony outline on the lateral wall of the anterior lateral wall of the frontal sinus over here. Then you can see there are multiple breaks over here on the patient's anterior lateral wall of the frontal sinus. You can see there's deficient bone over here. There's no bone in the superior area of the left side frontal sinus over here, and you can see still some mucosal collection, hypertrophy over here. So as we keep on going behind superiorly, you can see there's a bigger area where there is a huge deficiency of bone over there. Probably that's the area from the top side when the transcranial approach was done. Maybe they had gone from the patient's left side area for the approach, and as you can see, there's a huge collection in the patient's left side frontal sinus. You can see some altered double density sign. It could be anaerobic infection, it could be collection or entrapment of air within the so it could be fluid, air, liquid, gas shadow over there. two densities, different densities over there. And you can see there's multiple abnormality in the surface of the sinus area over there on the top side. So as I keep going behind, you can see there's a lot of rough new bone formation. Probably this is basically mostly looking like osteotic changes in terms of healing. When the bone heals, it heals in an abnormal way if it is a major surgery which was performed earlier. So the bone heals, and that heals irregularly, maybe osteotic, maybe infected bone. And you can see there's a lot of abnormal bone growth within the sinus, as you can see right now. So probably this is the downward projection. You can see that's the left frontal recess here. It's completely occupied. There's a lot of bony ingrowth, and you can see abnormal bone growth towards the inner part of the frontal sinus. So you can see, if you can see and focus on the patient's right side, you can see a huge downward inferior growing bony projection that is having a double density, different density shadows. You can see over here where my mouse is, you can see there's a lot of hyper intense shadow, but towards the end of it there's a lot of gray collection along with some minute dispersed bony areas. So this could be either because from the transcranial approach where they had drilled off the bone, or it could have been because of the trauma. The road traffic accident may have led to the multiple bony fragments which got healed off in an irregular way. So there's no history as such regarding that point, so we may assume either of the two could have happened. But you can see the frontal sinus is very much narrow in terms of space on this patient's right side. So as I keep on going, so one more point, you can see over here there's an actual bony segment over here towards the floor and the posterior part of the frontal sinus on the right side. See, we have reached the recess on the patient's left side frontal sinus, but it's still the sinus on the right side. So you can see we are going behind, the floor is still intact. Now we've reached the frontal recess on the right, but we had reached the frontal recess on the left a little earlier. So you can see that's the huge bony segment again. It's totally a different separate segment you can see over here within the sinus. This could be abnormal bony fractured segment, which is right now seen to be as an isolated segment, completely having no attachment whatsoever to any other bony wall inside. So once we're going to open the patient's frontal sinus from the right endonasally, we should be looking for these bony projections. We may remove that, we may drill off the excess bone to gain more access within and to see for the actual CSF leak site. We may also open the patient's left frontal sinus just to clear the area of what you can see. It's all opacified structure inside. So you can see that's the floor of the sinus over here, which is eventually the roof of the orbit, which looks normal. We may have to do a orbital transposition as well, for which we may have to remove all that bone. So the floor of the frontal sinus, which is basically the roof of the orbit, for the orbital transposition, so that we can gain more space after we perform the right-sided extended modified DRAPS procedure to have a head-on view to the CSF leak site. So moving on behind, you can see still that's the frontal recess, and ideally this should be the posterior wall of the frontal sinus, exactly behind which will be the frontal lobe of the brain with the dura layer popping just behind. So you can see there's some gray shadow, which is definitely brain, because that is brain, that for sure, that is brain. So that is intracranial cavity, assuming that this is the same intracranial cavity which is completely projecting anteriorly on the posterior wall of the frontal sinus. You can see that's the lateral most part of the frontal sinus with air within. So as I keep on going behind, as you can see, that's the soft tissue opacification. That's the intracranial cavity for sure. And that's the frontal recess, and that's the supraorbital cell on the left side. So if we compare both these sides and consider this as also at the same level, this should be the area of the supraorbital cell in continuation with the frontal sinus, and this should be what we think is the intracranial cavity. So as we go behind, yes, that's the brain there, and you can see a lot of changes here in the structure of the cortical structure of the bone over here. You can see a lot of changes. There's a through and through gap over here. You can see there's no protection of the skull over here to the brain. There's one open channel here, so probably they must have done a craniotomy, a supraorbital craniotomy, to approach within the frontal sinus directly head on, because the neurosurgeons usually, whenever they have to approach to the frontal sinus, they usually do a supraorbital craniotomy, or they basically go as a transbasal approach through the hemicoronal, or you can say the bicoronal incision, basically keeping the pericranial flap intact. So you can see there's a through and through defect in the bone, and you can see there's this is a very tricky part over here. This was the part which I had to literally study a lot on the CT scan. I had to observe this area a lot. Now please pay careful attention. This is the frontal recess here. You can see right there. That's the frontal recess, the most posterior most aspect of the frontal recess. Now I'll cross check this. I'll show you in the surgical video part as well. See this segment you can see over here, that's the posterior wall of the frontal sinus. That is basically just this bone is the posterior wall of frontal sinus. Exactly behind this will be the frontal lobe of the brain, and you can see that is also the medial most part of the posterior wall of the frontal sinus. You can see there's a through and through gap over here, and you can see that's the air within the intracranial cavity, and that's the brain there. That's the brain, and you can see this is the orbit right there. That's the medial wall of the orbit in the most superior aspect. That's the lateral most part of the supraorbital cell, or the most posterior part of the frontal sinus over here where my mouse is. But as you can see, this is the fractured segment, the initial fractured segment which the patient had, or he acquired from that road traffic accident, which the neurosurgeons tried to access through this transcranial craniotomy basically. And they tried to approach this area. They must have plugged a lot of fat over here in this area, but somehow it did not hold much longer. So I'm assuming that's the first site of the CSF leak, the skull base defect, which is exactly in the inferior lateral part of the frontal recess. So we may have to do a very huge drafts, modified extended, to access this area. So you can see that's a very bony, thick area between these two troughs. You can see there's a gap over here, and that's the actual defect. So we may have to drill onto this bony segment and to this bony segment, removing the medial orbital wall and doing a orbital transposition. So the orbit is pushed laterally like this, and we get more space over here after doing the drafts procedure, that is the LOTHROPS, HEMI-LOTHROPS probably, and taking away this osteotic bony segment, and then uncovering the underlying skull base defect, making it a little bit bigger than what it exactly is, and then plugging the fat entirely, and then putting the free fascia graft and the Haddad flap over it. So that is the first skull base defect we could see for sure. And then we're going to go behind. You can see the orbit and the skull base is so in close relation to each other, and you can see that few foci of air, that is basically pneumocephalus. That's the cribriform right there. So up until this point there was no cribriform at all, but as soon as we cross the posterior most wall of the frontal sinus, you can start seeing that's the cribriform here. So in case anyways we're going to perform that LOTHROPS. So our first landmark for before the LOTHROPS begins is the first olfactory neuron, right? So as the cribriform plate starts over here, that should be the first olfactory neuron, a little anterior to it. So we're going to drill the entire bone, whatever is anterior to this first olfactory neuron. You can see there's a lot of abnormal bony formation over here, and if you compare the patient's left side skull base over here, the patient's right side skull base is way more pushed inferior laterally onto the orbit, and you can actually see the orbit is also getting pushed down a little bit. So we may have to drill all that bone, push the orbit laterally, create more space manually inside so that we can actually manipulate it inside. And you can actually see the amount of bony destruction that has happened here because of the transcranial approaches performed twice in this patient. So this is definitely going to be a challenging case, and I'm pretty sure that I'll be able to expose each and every skull base defect like a piece of cake, walk in the park. But for that, you need a lot of experience, a lot of thorough knowledge to the in the radiological department. You need to have a good help from the senior radiologist team to confirm your doubts, and later on you can just go through the basics yourself. So you can see that's the air foci, pneumocephalus. That's the hyperostotic, thickened, fibrotic skull you can see inside. So as we keep on going behind, that's the normal skull base. You can see behind, there's no breach in the skull base here. The nasal anatomy looks quite normal. A little bit of spur on the patient's left side. So we may not take the head art from the patient's left. We will try to take it from the patient's right only. And we'll try to take a rescue flap just to be safe from the left side. So what else? We need to see any secondary site for the CSF leak. First site was this. We could actually see that's the first site of CSF leak. That's a huge defect inside. Now going on posteriorly, just keep close attention to the skull base only. The skull base is huge here. So you need to see for any defect, whatever you can see in the skull base behind. So far so good. You keep on going behind, see for any defect over there. Okay, you can see a lot of collection over here immediately. There was no collection up until this point, where you can see, since from this point onwards you can see the collection happening over here. It could be polyposis, it could be some allergic reaction or allergic changes inside. So going behind, trying to look for any skull base defect as such. You can see there's one defect I can see over here. There's no bone actually. There's a discontinuity in the skull base over here, so probably you can see the amount of the air foci in the brain is immense. That is basically pneumocephalus as a result of the ball valve effect. That's the pressure from the external environment becomes more, so the air gets pushed into the intracranial cavity through the skull base defect. That is why, because the pressure from the external environment becomes more as compared to the pressure in the intracranial cavity as a result of the skull base defect. So the air gets sucked in, gets pushed basically because of the ball valve effect, and then starts creating a buildup of air inside. So that was the probable site of the defect, which we may have, this one probably, which we may have to encounter. So basically what I'm going to do is I'm going to flush the entire skull base on the right, first on the right, probably later on the left. So on the right side, what I'll be doing is to do a full house fess on the right side. I'll open the sphenoid, anterior posterior ethmoids completely, open the maxilla completely, A to Z, everything I'm going to open to full house maximum limit, not going to leave a single cell behind. So I'll be performing an actual full house fess, and then I'll be studying the landmarks. I'll be showing it to you step by step so that even a beginner can learn how to do fess from this surgery video, and then skull base also. So later on I'm going to open the sphenoid, the frontal, and then do a drafts later on. First full house fess, then drafts, and then sealing of the defect or defects, multiple defects basically. So I'm going to clear all this. You can see the maxilla is definitely not huge as compared to what it is on the patient's left. To begin with, the patient's maxilla is really small as compared to the patient's left side. It's not that wide. It is big, but not that wide as compared to the left. And towards the posterior end, you can see the orbit is kind of very low. You can see there's some kind of floor of the orbit fracture over here. You can see that. You can actually see that the patient's right side orbit is kind of stooping down. On the left, if you can see, this is the horizontal plane. If you can draw a line like this, if you can pass this line over here, this is actually, this horizontal line, if you draw, it's actually passing midway through the orbit above the level of inferior rectus on the patient's right. So this could be either a tilted scan, or it could be the case that the patient's orbit on the right side is kind of stooping down, because you can see the floor of the orbit is kind of really low. That is actually reducing the volume of the patient's right maxilla, and you can see that's the oblique floor of the orbit. So this must be the fracture that the patient acquired from the first accident, because the neurosurgeons cannot go this deep down through the orbit to cause this fracture. So this is basically a healed, abnormally healed fracture from 10 years back from the first RTA, the RTA, basically the road traffic accident. So you can see you need to evaluate this as well. So once you open the patient's maxilla, you may see that the floor of the orbit is kind of very, very low, but there's no actual sense. It doesn't make any sense to repair this floor of the orbit right now at this particular surgery, because it's been 10 years and the patient does not have any issue with the right side eye. So you just have to expose it. There's no compulsion as to treat this floor of the orbit right now, unless the patient has an enough thalamus inside, and if at all that's the case, you can get it done, but not right now. So you can see that's the collection in the maxilla, and a small maxilla towards the most posterior aspect. So you keep on going behind. You can see now, what else? Now you can go behind. You can see the sphenoid is basically not normal over here. The entire sphenoid is full of some kind of soft tissue opacification over here. That's the entire sphenoid, completely opacified. It could be the CSF, which is trickling down from the skull base anteriorly. So you need to flush the entire skull base properly. The right and the left sphenoid both are fully occupied. No skull base dehiscence as such on the sphenoid aspect. This is the ICA area, and that's the basic optic nerve over here. That's the optic nerve over here. So the area of the optic nerve here and the optic nerve here looks okay. Slight cortical bony damage I can see over here. Could be because of the demineralization of some metabolic issue. Does not look like a fracture to me over here. That's the ICA area. Okay, so it's worth checking out the sphenoid. Anyways, we're gonna do a full house fest. So possibly we have 2 fractures going on over here in the skull base. No, not more than 2 I could see. Not more than, this is the second one possible defect I can see. That's the second defect site, somewhere around here in the posterior ethmoids. We need to explore that. So once we do that, we need to seal the deal and repair it very nicely. So that you can see that's one of the most abnormal looking frontal sinus I've seen in my life, following a road traffic accident and having a CSF leak. So I'm going to go with the MRI again. I'm going to show you some MRIs. So this is the MRI scan I'm going to show you. These MRI scans are not that clear, but whatever scans I have right now for you, I'll try to explain this. So this is a coronal MRI, T2 weighted MRI scan. You can see that's the CSF in the patient's frontal area. That's the frontal sinus on the patient's right side. And as I keep on going behind, that's the patient's left, that's the patient's right frontal. You can see that's the CSF in the patient's right frontal. That's stooping down, that's flowing down into the frontal recess area in the upper half of the sinonasal area, just towards the skull base. So as we keep on going behind, so you can see that same fluid intensity, CSF intensity, you can see in the patient's maxillary sinus as well. But that can be some secretions in the sinus as well. But these are exactly like CSF, so we can call these as CSF-like intensity. So going on behind, so that was the first area. which we could see very clearly on the CT scan. But these MRIs are showing the CSF collection, that's for sure. Going behind, you can see that's the CSF in the brain. That's the air foci over here. Let me show you. That's the air foci over here. That's the CSF in the brain. Now the ventricles on this patient are completely widened up. They are huge ventricles for this patient. The patient also has some kind of hydrocephalus, raised ICT. So you can see that's a huge area of the air foci on the MRI intracranially. So that's the pneumocephalus basically, and that's the dilated ventricles in the patient's brain, the lateral ventricle basically. And you can see the lateral ventricle on the patient's right side is completely compressed as compared to the patient's left side lateral ventricle. So I'm going to go anteriorly. See, that's the lateral ventricle of the patient. It's completely dilated. The patient has hydrocephalus, and as we go behind, that's the patient's right ventricle, the right lateral ventricle basically. And you can see because of the air foci superiorly, it's kind of pushing the lateral ventricle on inferior aspect. We're going to go behind. That's the MRI I have, the best one I can say for sure. So we need to see for that second CSF site if at all it has picked up, the MRI has picked up actively or not. We need to see that. So we need to see for any CSF intensity flowing in the sinus area just towards the posterior ethmoidal skull base. You can see a thin black line which denotes the skull base bone which is intact. Even if at all the second site has not shown any active leak, or this MRI did not pick it up at that particular time, it's fine. We just need to find any discontinuation in the black line, and we can just assume that that's the area of the skull base defect that we could see on the CT scan. But we do need to cross confirm that when we go and operate on the patient, and hence that's the reason why I need to always flush the skull base completely in all cases of road traffic accidents, raised intracranial tension, because the moment, if you assume that there's only one skull base defect up there and you seal that defect, all that pressure will reduce and get diverted to some other area which was not active before and may become active the moment you seal that main primary defect. So that you need to keep in your mind while you're performing skull base reconstruction. So that is why you need to completely flush the entire skull base A to Z, so that once you seal the main primary defect, you're going to wait for some time. You're going to go and ask for the anesthetist to perform the Valsalva if possible, and then you need to check for CSF leak from any secondary or tertiary sites. So that is how we come to know. Even on the scan, even if on the MRI, the MR cysternography, CT cysternography did not show any active leak at that particular time, but if it is showing on the CT there's a skull base defect somewhere behind, and intraoperatively you also see there's a skull base defect, you can go for sealing that particular area after you have confirmed either with an active CSF stained with fluorescent is coming out, or you can go and ask the anesthetist to perform a Valsalva. But make sure you do not keep on asking the anesthetist to perform Valsalvas once you have repaired the initial CSF leak site. Once you've put the fat plug, once you've put the tissue glue, the free fascia, never ever repeat or ask the anesthetist to give Valsalvas, because that may dislodge the fat or somewhat hamper the area of repair. Always make that sure. So I don't see any CSF intensity in the posterior ethmoid skull base though. So I just may have to go and check it, do the flushing of the skull base, and if at all, if there's any, I may have to go and seal that. So you can see that's the frontal sinus. You can see some CSF intensity that is posterior. Okay, so beyond that, I don't see any other CSF intensity. So I'm going to go and shift on to the patient's surgical video right now. And I'm going to be showing you each and every aspect of the skull base anatomy, how to do a full house fest, how to do a drafts, how to do an extended HEMI LOTHROPS, how to use a 0 degree and the 70 degree for your frontal sinus surgeries. And later on, I'll be also showing how I have used a navigation system for this case. I'll be showing you certain images, certain video clips of me performing the navigation system, how to differentiate the cribriform area from the anterior inferior frontal wall, that is a frontal beak, while performing the drafts. So I'll be showing you the basics of navigation system use as well. So I'll shift to the video right now. So this is a surgical video, as we have discussed the scans already. So I'm going to move on to the surgical basics right now. So as you can see, this is the patient's right side nasal cavity. The very first step which I'm going to be doing is the decongestion. So this step allows me to visualize the anatomy within the patient's sinonasal area much better. So you can see I'm trying to use multiple pieces of net cell, also called as merocell, soaked with normal saline mixed with 3 to 4 ampules of pure adrenaline. So you can see that's the inferior turbinate at your 9 o'clock, going way beyond, that's the choana. So you can already see that's some kind of a deviation a little higher up in the posterior nasopharynx area. Hence my scope is not able to go. So I have to go down, and there you can see that's the choana area, that's the nasopharynx, and you can see a huge blood clot over there. So I'm going above and below, trying to show the area of the posterior nasal cavity. So there's some kind of a clot, and what you can see me doing right now is just to take out the nasal vibrissae, that's called as nasal hair. So to remove these hair is basically really important, otherwise they're going to keep fogging your lens. So I prefer to remove the nasal hair 1 hour, a few hours prior to the surgery. So what you can see, that's the CSF leak that is happening right there. So after decongestion, what I can see is directly head on, that's the middle turbinate along the septum, and what you can see right there is a clear fluid with pulsations, and you can see it is actually pouring out, and you can see a lot of, at your 12 o'clock, a lot of granular tissue, granulation tissue basically. So as per the scans, we could see that there is a defect in the posterior wall of the frontal sinus, and there's possibly one more defect. You can see that's the pus all around. So there's possibly one more defect in the posterior ethmoidal skull base as such. So there are 2 possible defects as per the scans reports, which we could see. You can see I'm just trying to give a nasal wash, take out all that debris, clots, and the mucopurulent secretions out there. So what defect, when we can see, we cannot see the actual defect right now, but we can see the CSF leak happening, and this is at the level of the axilla, which we can see right now. So you can see that's the middle turbinate on your 3 o'clock, and that's the defect, possible defect area at your 11. So you can see I'm giving a lot of nasal washes just to have a clear picture inside. Make sure you hold the endoscope erect, don't tilt your endoscope, otherwise it's going to give you a false orientation. So you can see that's the middle turbinate, and possibly at the very center that's the anterior ethmoidal artery area. Looks like an anterior ethmoidal artery area, but not sure quite yet. So the very first step after decongestion was to evaluate the anatomy and look for the possible site of leak. What I'm going to do next is to expose the area much more better. I might take away the lower 2/3 of the middle turbinate by keeping the upper 1/3 of the middle turbinate intact. So this removal of middle turbinate is definitely not going to hamper any anatomy inside. See, that's a high level DNS up there. It's going to block, it's blocking the area superior. You can see when I retract the septum midline, you can see there's a lot of space that it was blocking right away. So that's the space medial to the middle turbinate. So I'm going to put pressure on the septum with the suction freers and try to break, cause microfractures in that part of the septum, so it becomes much more erect. So if you try to break the continuity of the deviated septum by fracturing it, it tends to stay erect for a longer time. That will give you a temporary access to the blocked area. So that's the middle turbinate. I'm trying to microfracture right now by medializing it along the septum. So I can actually feel the micro crackles happening right now. You can see there's hardly any capillary ooze happening because I'm using the blunt surface of the shaft of the suction freres and not the tip. So if you're going to use the tip of the freres, it's going to cause mucosal bleeding. So again, I'm going to go for decongestion, reduce the edema of the mucosal surfaces. You can see there's a huge area of the middle meatus, and you can see the CSF pouring out from a particular area in the frontal recess. Little bit of capillary ooze, that's fine. You can always put pressure to stop that area from bleeding. So you can see mucosal hypertrophy in that particular area. Now, what you can see is a fluorescent green tinge to the CSF, and so I've asked the anesthetist to inject the patient with the fluorescein dye intrathecally. So you can see that's the CSF happening, and the CSF is stained with the fluorescein dye right now. So it becomes very easy for the surgeon to locate the site of the CSF leak. So where exactly am I right now is at the level of the most inferior part of the frontal recess. So what I'm going to do right now is I'm going to do a FES procedure on the right side. The very first step, what I'm doing right now is I'm taking out the bulla ethmodalis. That is the uncinate vertical process I'm taking out right now. Again, I'm back at bulla ethmodalis right now. So I'm debriding the bulla ethmodalis right now, and that is the ground lamella behind, you can see, which is the middle 1/3 of the middle turbinate. That's the horizontal part. That's the ground lamella. Now I'm back onto the vertical uncinate process right now. So the basic aim here is to have a wider opening to the middle meatal area. See, yet so far I have not taken away the middle turbinate. I have just performed a micro fracturing on the middle turbinate so that it has become stabilized along the septum. So if you can see, the middle turbinate is not moving at all. I have fractured the middle turbinate medially along the septum, and you can see that is giving me a lot of space to walk in the middle meatus. So what I'm doing right now is I'm using an upwards Blakesley along with the debrider and doing a mini FES surgery right now, taking away the anterior ethmoids so far, the vertical part of the uncinate, and then later on I'll be flushing the area with the lamina papyracea. I'll be exposing the lamina, the medial wall of the orbit, throughout from the lowermost part to the uppermost skull base level. The more tissues I remove, the more cells I take away. That's the maxillary sinus below. You can see that, right? So that's the choana. So I'm going to go below superior. That's the choana down there. That's the maxillary sinus opening from the posterior aspect. That is the area above of the anterior ethmoids. Behind the ground lamella will be the posterior ethmoids. You can see a small opening there. Exactly behind that will be the posterior ethmoids. So you need to flush the entire area, remove the uncinate, vertical and horizontal processes, then completely open up the maxillary sinus, expose the floor of the orbit through the maxillary sinus. That will act as a landmark. You can see I'm trying to debride the uppermost part of the vertical uncinate near the axilla as well. So you can debride the entire axillary mucosa, soft tissue, and expose the frontal process of the maxilla as much as you can. So that's going to give me a more superior vision the way I'm doing right now. So currently I'm removing the anterior ethmoids, which are flushed along the lamina papyracea superiorly. So you can see in some time I'll be exposing the lamina papyracea completely in its entire length. You can see I'm almost at the posterior ethmoid level. I've taken off the ground lamella as well with the debrider. Now you can see the frontal recess up there very clearly. You can see the frontal lobe of the brain prominence in the frontal recess sinus area. That's the second site of leak, which we could see on the scan, which is towards the posterior ethmoids. So you can see the glimpse of the lowermost part of the frontal sinus area and the recess area as well. So what I can see me doing right now is, again, I'm going to go with the debrider and debride the axillary area as much as I can. So again, with the debrider, you can see I am in the patient's maxillary sinus, trying to take away all that soft tissue so that I can have the maximum opening to the maxillary sinus and expose the floor of the orbit. So far, almost I've taken away the vertical process of the uncinate. You can see the glimpse of the lamina papyracea right now. My debrider is against the lamina papyracea. You can see that moving. That's the lamina papyracea, thinned out lamina papyracea. I'm just taking away the anterior and the posterior ethmoids. So you can see with the debrider, I'm back again at the axillary level. I'm at the axilla. I'm debriding away all that soft tissue, so that I can directly have a head-on view with the 0-degree endoscope on the frontal sinus area. That's going to also help me do the DRAPS procedure on the right side more efficiently. This is all lamina papyracea you can see against my debrider, and that's the axillary level up there. So that's the frontal process of the maxilla. The bone which you're going to feel right now at the level of the axilla is the frontal process of the maxilla, superiorly and laterally. You can see I'm just debriding all that cellular area of the anterior and the posterior ethmoids. That's the posterior ethmoids where my debrider was, where the second side of the leak is basically. You can see that's the posterior most attachment of the middle turbinate, which is definitely in the posterior ethmoidal area. So you can see the amount of visualization we have achieved just by performing a FEST procedure on the patient's right side. That's the entire lamina papyracea exposed superior to inferior. I'm coming back on the axillary area, trying to take away all that soft tissue very carefully, not trying to damage any neurovascular structure. That is a remnant of the posterior ethmoids. You can see I'm trying to debride right now superiorly, with the active ongoing CSF leak happening from the frontal sinus area up there. You can see that's the agonized cell above, along the axilla and the uppermost part of the middle turbinate, anteriorly. So I'm again at the posterior ethmoidal level superiorly, just trying to take away all that soft tissue, just to locate and visualize all the anatomical landmarks. So I'm almost towards the skull base above. That's the part of the superior turbinate behind. So I'm going to go medial to the middle turbinate and try to open the sphenoid sinus. I'm going to show you how to approach and perform that particular technique. That's the posterior most part of the middle turbinate, where the sphenopalatine artery will arise from just behind the posterior wall of the maxilla, above and behind the crista ethmoidalis. So my aim here to open up the maxillary sinus is to locate the floor of the orbit as a landmark. So I'm going to wash, and then I'm going to do a suctioning just to remove any clots and to keep the surgical field clean. That's the choana behind. That's the huge choana. You can see some mucoid secretions up there in the choana. So you can see we have a very huge opening and a good access for our CSF leak site. Now that's a 0-degree endoscope, and what you can see right now is the lowermost part of the frontal sinus area with an active CSF leak stained, the CSF stained with the fluorescein dye. You can see the periodic pulsations of the brain, and with that the CSF leak also happening periodically. It gives a pulse every 2 or 3 seconds and minor pulses every second. So that's the choana down there. That's the maxillary sinus, a huge maxillary sinus. That's the floor of the orbit where the suction is right now. That's the posterior most part of the posterior ethmoids. That's the frontal recess and the sinus above from where the CSF leak is happening right now. At your 9 o'clock is the lamina right now. So what you can see me doing right now is I'm trying to do the lateralization of the middle turbinate, and along with that the superior turbinate as well. But while I'm doing this, what you can observe here is there's a huge superior septectomy which has already been done on this patient. But when this patient's history was taken, the patient denied having getting the endonasal approach done from any other surgeon, and there was no history as such of this patient undergoing a endonasal procedure. But you can see there's a very well devised superior posterior septectomy, and you can see the middle turbinate from the patient's left side as well. So assuming that this patient was operated endonasally before, I may have to look for a proper anatomy to know whether or not the Hadad flap was taken previously. So I'm going to harvest the Hadad flap as well later on from the patient's right side. Now I'm trying to open the patient's sphenoid. You can see there's a sphenoidal at the area where usually the ostium is. You can see there's a lot of polypoidal tissue. So what I'm doing right now is I'm coming with the debrider from the patient's left side through that opening done by the previous surgeon. What I'm doing right now is taking away the superior turbinate, lower 1/3, which has converted itself into polypoidal tissue, and just between that posterior septum and the superior turbinate will be the sphenoid natural ostium, 1.5 centimeters above the superior bony coronal margin. So that's the superior turbinate bone. So it's safe to remove the lower 2/3 of the superior turbinate without hampering the olfaction. So there you can see that's the sphenoid sinus ostia, very clearly seen. Make sure you don't damage the lower half of the sphenoid ostium, because you may injure the sphenopalatine branch for the Hadad flap, which we are going to harvest in some time towards the end of the surgery. So you can see that is the sphenoid sinus opening, that's the natural ostia. Now, the reason I have opened up the sphenoid sinus is to check whether or not there's some third CSF site leak. So you can see there's no CSF leak happening in the sphenoid. It's completely clear. There are no pulsations as such. There's no fluorescein stained CSF as well in the sphenoid sinus. But what you can see here, that's the frontal lobe prominence. You can see very clearly. That's the frontal sinus, what you can see right now. See, this is still a 0-degree endoscope, and because of the debridement of all the tissues around, I can actually see with a 0-degree the entire frontal sinus lower half. So what you can see me right now, what I'm doing is now it's the time for me to take away that lower 2/3 of the middle turbinate, so that as to have some extra space to walk inside. Now, once I have taken off the middle turbinate, make sure that as you go posteriorly, you do not injure the stump of the middle turbinate near its posterior attachment. Otherwise, you're going to injure the sphenopalatine branch to the middle turbinate, and that's going to cause a lot of bleeding. So the trick to avoid that is to cut the stump a little ahead, so that you avoid lacerating the artery as such. So you can see I've taken off that middle turbinate, and you can see I'll later on use that same middle turbinate, keep that in normal saline, preserve that tissue, and may use that middle turbinate mucosa as a free fascia graft. I've always done that previously in my surgeries as well. I've used middle turbinate fascia as a free fascia graft for many CSF and skull-base tumor cases as well, to seal the leak and any skull base defect. So you can see I have a huge area inside to work. Now I'm going to take off that middle turbinate out. You can see that's the stump there. Make sure you cut that a little ahead, anterior to the stump, so as to avoid any arterial spurt from the middle turbinate artery. So I'll show you how it's done. So you just take your turbinectomy scissors, make it horizontal, somewhat vertical, and cut a little anterior to the stump. And then later on, you can cauterize the stump as per to your convenience. So you can see that is the stump, and ahead of that, I've
cut the middle turbinate. That's the middle turbinate. You can see I'm going to use it later on for harvesting the free fascia graft. So now comes this, you can see that's the second side of the leak, way posterior towards the posterior ethmoidal skull base, more towards the lamina, and that is the frontal sinus base. You can see with a lot of CSF leak happening from up there. That's a huge opening, but beyond this, we need a head-on approach. See, I'm not going to go external, do a transfrontal procedure by the external method. I'm purely going to go endonasal, because this patient, as already discussed, has been operated twice by the neurosurgeons out there, and twice they have been operated by the transcranial method to no avail. So you can see that's the second site of the CSF leak with active CSF pouring on actively from a defect up there. And you can see there's no communication between the first and the second possible CSF site. So if you have a doubt that whether or not is this the same CSF which is just pouring from the primary site and getting a false assumption, well, that is a different site. You can see I'm suctioning it just to clear your doubts. You can see I'm suctioning it, and now you can see it's actively pulsating there, and it's actively pouring CSF. Can you see that? So had it been the CSF coming from the active primary site, you can see right now, there would have not been any pulsations at the secondary site. So this is an actual secondary site for CSF leak, and that's the sphenoid down there. So you can see that's the posterior ethmoids basically. So one leak is in the posterior wall of the frontal sinus towards the lateral aspect, which we cannot see right now, for which I'll have to do a draft, which I'll be doing right now. So I'll show how to do a draft procedure on one side, extended drafts on the right basically. It's not the usual drafts, it's an extended drafts on the patient's right side. That's the middle turbinate, upper 1/3, you can see right there. And that's the area of the cribriform behind, where you can see that's the cribriform mucosa. That's the olfactory mucosa right there. But anteriorly will be the floor of the frontal sinus. So the aim here is to elevate the mucosa and reach, see that's the olfactory epithelium right there, the yellowish white, and anteriorly is the floor of the frontal sinus. Where my frieze is right now, exactly at that level, will be the floor of the frontal sinus, a little behind. So you can see by pushing against that septum, I have made more space inside. Now there are many methods to do the incision here. Either you can use a coblator to have a bloodless incision. You can use a pencil Colorado tip needle for cautery. Or you can just use a normal frieze and just put pressure against it and elevate the mucosa along with a frieze suction. So I've chosen to do it with a frieze, and along with a frieze suction, you can see I'm using a neuropathy. You will see the very first structure when you take that mucosal elevation. The very first structure you'll see is more towards the lateral aspect, is the branch of the anterior ethmoidal artery. And exactly behind that, more towards the medial aspect, will be the first olfactory neuron. So that's the artery probably, and exactly behind that, more medially, would be the first olfactory neuron. So I'm assuming this is the first olfactory neuron, what you can see right now, a thick white cord. So that is how I could see the first olfactory neuron. And what I'm doing right now is I'm calibrating the neuro-navigation system, and I'm putting the probe just at the area of the first olfactory neuron, and I'm cross-confirming that on the NEURO-NAV system, which I'll show you towards the end of the surgery, that how to use a NEURO-NAV. See, after confirming the location of the first olfactory neuron, what you can see me doing right now is I'm drilling on the frontal process of the maxilla. I'm going to keep on drilling the frontal process of the maxilla laterally and superiorly till I find the external skin. The limit is the external skin. At the same time, you can see I'm trying to debride away all that soft tissue just to have more visualization inside. You can use a debrider, you can use an angled forceps, whatever works or suits you. See, step by step, I'm going to show you, skipping some steps in between, but the most important points and the steps I'll be highlighting in this video. You will be able to see gradually we'll be having a very huge opening head on for the frontal sinus. See, I'm again drilling on the frontal process of the maxilla. So we are very superior to the orbit. So the place where we are drilling right now is actually superior to the orbit. So this is not lamina papyracea. Lamina papyracea is way below the place where I'm drilling right now. Where I'm drilling right now is the frontal process of the maxilla, and it is way anterior, where you won't have the lamina papyracea. See, I'm drilling very superiorly, which is way above the lamina. So I'm drilling on the frontal process of the maxilla. You keep drilling it, you'll get a soft tissue, which is a skin. I'll show you. See, that is the skin. See, when I'm pressing against it, it's very soft. And I can cross confirm that by putting my finger on the patient's external aspect and feeling the burr as such with a finger. So I keep drilling the bone. The outer limit should be the skin laterally. The outer limit should be skin superiorly. Always remember that. So keep drilling till you get the skin laterally and superiorly. Just make sure you do not drill on the cribriform plate and on the posterior wall of the frontal sinus. Otherwise, you will enter the intracranial cavity, which is not good. So you can see my assistant is giving constant washes, and you can see that that's the posterior wall of the frontal sinus already visible right now. So I'm going to drill inferior to superior so I can actually expose the entire frontal sinus head on. You're going to find this a little difficult if you're a beginner or if you're doing this procedure very initially. So make sure that you have a good assistant that can keep giving you a good amount of washes inside. Also, you have to have a suction alongside the washes, irrigation, so that it can suck out all that debris which is flying around, the bone debris basically. You can see that's the pulsation and the CSF leak from the frontal sinus. So keep drilling. As you can see, I'm drilling on the lateral aspect of the frontal process of the maxillary bone. I'm going to keep drilling till I find skin on the lateral aspect. You can see that's the skin up there, but there's a thin layer of bone still left, so I'm going to drill that. You can see the pulsations have become more prominent. That's the bone along the frontal sinus anterior wall. So where I'm drilling right now is the frontal beak basically. So the frontal beak will be facing anterior inferior, and the frontal process of maxilla will be on the superior lateral aspect. So you drill all of that, and skin will be the external limit everywhere, superior and lateral. You can see there's a lot of bone that still needs to be drilled superiorly and superior laterally as well. That's the bone right there. But make sure, do not drill on the posterior wall of the frontal sinus as such. Otherwise, you'll directly open up the patient's frontal lobe. That's the cribriform plate down there. Be aware of that. Don't go too posteriorly. You just have to drill everything that is anterior to your first olfactory neuron. You can see there's a high level DNS that is giving me a lot of issues here. It's a narrow space I'm walking in superiorly. So you can see I'm now trying to drill the bone which is most superiorly right now. You can use an angle shaft, 15-degree angle shaft for more feasible drilling inside. So you can see gradually, slowly we are opening up the patient's frontal sinus head on, the anterior wall basically. So always keep the first olfactory neuron under vision so as to not injure the cribriform plate. That's the first olfactory neuron right there. So anything anterior to it, midline, lateral, you have to drill so as to open up the frontal head on. So you can see I'm going anteriorly. That's the frontal beak that I'm drilling right now. So once you take away the frontal beak entirely, you'll be having a head-on direct approach to the frontal sinus. See, at your 9 o'clock, that's the skin, you can see very clearly. Make sure you do not drill through and through the skin, otherwise that's going to be an issue for the patient's cosmetic appearance. See, that is all skin, very soft right there, and anything behind that, if there's a bone left, you have to drill that. So make sure once the skin has reached, you're not supposed to drill beyond that. Now this is all frontal beak, which I'm going to drill right now in some time. So you can now see that is the area of the anterior inferior frontal beak, and now it's the area of the cribriform plate down there where my suction is right now. So always keep the first olfactory neuron in your sight, and anything that is anterior, you can drill that very easily. So what you can see on the screen where my suction is all the frontal beak. So once we remove that, we'll be having a head-on approach directly on the patient's posterior sinus wall. You can see the huge bulge of that's the suction, that's the bulge of the frontal lobe of the patient's brain. So you can see that's very close to the anterior wall of the frontal sinus, and that's all the skin out there at your 9-11 o'clock position. So I need just to drill that. So what you can do, you can also use a upturned bone punch. So you can either use a straight punch or an upturned bone punch, and you can punch it out. So you can see the punching is much more easy. So if you have an angled burr, the angled shaft, 15-degree angled shaft, you can use that to drill very easily. If you don't have that, you can definitely use this bone punch, the curved bone punch. As you can see, I'm trying to use that, and I'm able to punch out a lot of bone in a very less amount of time as compared to drilling. So you can see that is all the posterior wall of the frontal sinus, and you can actually see the CSF leak coming right from there. So you can see I'm resuming with my drilling, just trying to carefully finish off the lateral touches till I reach the skin all sides. So you need to be very careful of the posterior wall of the frontal sinus, because exactly behind that will be the frontal lobe of the brain, which you do not want to damage. So with few cases in draft 3 or LOTHROPS procedures, you will definitely come to know the layout of the anatomy. So you need to practice initially on the cadavers, so you need to know, so you can learn where the anatomy of the lateral wall, the frontal beak, and the posterior wall of the frontal sinus lie. So you can see I'm coming back onto the bone punch, taking off the bone. So I'm using a combination of both the bone punch and the drill. You can see how the bone punch is easily allowing me to take off all those bony parts which are more lateral. So if you have an angled shaft, a burr, you can easily drill on that. But you can see this bone punch is actually helping me a lot as well. You can see that's the complete posterior wall of the frontal sinus, very much in view right now. So you can imagine if we remove all that bone, all that frontal beak, anything which is anterior to that of the cribriform, we'll have a very, very good exposure. So where I'm drilling right now is almost towards the center of the frontal beak. You can see I'm giving thorough washes to remove all that bony debris. You can see the actual high flow CSF from the defect, which is much more visible right now head on. You can see the flow of the CSF. Now, going on further superiorly, you can see I'm using a ball probe, and I'm actually trying to palpate the anatomy of the area. So where I am right now is basically the frontal sinus. There's a septations within the sinus. As you can see, I'm going to puncture through. So this is basically a septation that is present within the frontal sinus. So I'm going to drill on that septation. So you may get confused whether as that is a roof of the frontal sinus. So you need to confirm that before you drill on to that septation. So I confirmed that this was a septation and I'm now drilling on that. Once I drill that, you can see I'm using a bone punch again after I have made it bony thin, eggshell thin. That's the mucosa attached with it. You can see now that is probably the that could be the fractured bony segment from the previous traumatic experience, as well as from the transcranial route this patient was approached as well. So this could be the fractured bony segments towards the roof of the frontal sinus. You can see I've taken away that septation, probably query fractured bony segment. And what I can see, once I remove that, I'll be able to see the entire superior half of the patient's frontal sinus. So I'm using a straight Blakesley, trying to remove all that bony segment. Give it a thorough wash, remove all the blood clots to have a good visualization inside. You can see that is the superior half of the frontal sinus. And where the CSF leak is happening right now is in the inferior lateral part. So you can see that's the whole superior half of the frontal. So I need to drill more bone from all sides to have more visualization as such. Now you can see, if you can rewind the video, you can see that actually you can see the defect head on, through which the CSF is actually pouring right now with high flow. That is a huge defect. You can see a blackish shadow over there. That is actually the defect, and through which you can see the CSF coming out. So that's frontal lobe of the brain exactly behind that, and that's the superior half of the frontal sinus. You can see the dome of the frontal lobe above, and you can see a lot of irregular bony margins on the posterior wall of the frontal sinus as such. That could be because of the previous road traffic accident, or it could be because of the transcranial intervention done. So you can see I'm trying to drill away all that frontal beak anterior superiorly till I reach the skin superiorly. That's the skin at your 9 o'clock, and I can see the roof of the frontal sinus superiorly as such. So that's the upper half of the frontal sinus. You can see very clearly right now the entire frontal sinus. This is a huge one on the right side. And now with the help of a unilateral extended drafts, you can see we have achieved to manage a huge visualization inside. So I'm going at 11 o'clock for the drilling. That is towards the orbit. So I might have to do an orbital transposition later on. So a little bit of drilling and now the bone punch. Now the bone I'm removing right now is a part of the frontal beak that is present more towards the orbital part, towards the roof of the orbit. So that's going to help me do the orbital transposition if I at all need to go a little above the supraorbital area. You can see now I'm pressing on the orbit and the skin from above. That is the movement, and that is all skin all around. So I've taken away the entire bone, and that is only skin near the external approach. You can see that those are little bony fragments I can just take away, and this is all skin everywhere on the lateral aspect. So I've taken away the bone completely on the lateral aspect, which is only skin right now. So this is going to help me manipulate the area a lot more easily. And you can see the defect head on right now. So if we can rewind the video, as I was saying some time back, we were not able to at all see the defect. And right now, after having removed all that bone with the help of a 0 degree right now, we are able to see the entire frontal right from its most inferior to its most lateral and most superior aspect of the frontal. So we can see a huge bony defect, and through which there is a high flow CSF leak. You can see there is no bone at all, it's all skin. So I'm going to drill that irregular bony convexity on the posterior wall of the frontal sinus. So you can see the defect is actually hidden between the two bony troughs the one trough which is anterior and the one which is posterior. Between these two troughs is the defect. So what I'm doing right now is I'm going to drill away any irregularity of the bone which could have been caused by the previous neurosurgical intervention or the road traffic accident. So all these are fibrosed osteotic bony margins. We need to drill and make it smooth. For one more reason is for when we put the free fascia graft and the Haddad flap, it requires a raw surface area and a flat surface area. Now what you can see right now, I'm trying to transpose the orbit right now. What I'm doing right now is I'm transposing the orbit and the skin above to get more visualization to the defect. You can see there's a small bony plate exactly at my Freer's suction right now. There's a small bony plate you will be seeing. If I happen to drill that as well, I'll be having furthermore direct approach to my defect as such. So you can see that's a huge opening. That's a huge exposure I've done on the patient's right side, unilateral extended drafts. That's the cribriform behind down there with the first olfactory neuron. Now you can see that's a good exposure on all sides. Now I've started doing the four-handed technique right now. Up until now I was doing two-handed technique along with my assistant, but now I have shifted on to a four-handed binostril technique for the approach. So you can see that's a huge opening up there. So what I'm going to do right now is I'm going to drill on that bony projection on the posterior wall of the frontal sinus. Carefully I'm going to drill that, making sure I do not go and injure the frontal lobe of the brain, because exactly behind this will be the frontal lobe of the brain. Now the reason why I'm drilling this area is because the actual defect, which is a huge defect which you could see sometime back, is actually lying behind the angular edge of this bony projection. So I need to drill this and make it flat and uncover the actual defect which is behind. So it could be a bigger defect as to what we can see right now. So we need to drill this and uncover the original defect from below. So you can see careful dissection, careful drilling. You can see the endoscope is stable. The drilling is also stable. So you can see there's a defect down there as well. You can actually see the arachnoid as well, a thin whitish membrane. So what I'm going to do is I'm going to take away all that fibrotic thick bone, expose the defect head on, and assess the area of the bony defect altogether. So you can see that's the defect down there, and the CSF is also coming from up there. So you can see that's a huge defect that we've uncovered after drilling the bone. So if you don't drill and make it flat and you just try to plug the fat in with an angled ball probe without drilling this, the step which I'm doing right now, had you just put the fat inside without drilling and uncovering this bony landmark, you would have had a good amount of failure rate for this patient. So you can see now, after drilling on that bone, you can actually see how big the defect was from within. Can you see that? So this is a very huge defect that was possible only after we tried to drill on that bone. And you can see actually now that is the intracranial cavity behind. So what we're doing right now is just to define the margin, the bony margins, by using a tela massa. The neurosurgeons call this dissector tela massa. We skull-based ENT surgeons call that as a Cortels dissector, right? So you can see that CSF actually pouring out, stained with fluorescein dye, and you can actually see and assess the actual defect here. That's the intracranial cavity inside. You can see how the CSF is pouring out with intracranial pulsations. So imagine if you didn't drill on that bone and you would have just plugged fat inside, which a lot of skull-based or ENT surgeons will claim to do it that way. Well, I beg to differ, is that I would definitely not follow that technique. I don't want the patient again on my operation table with a failure. So I will definitely go and drill on the bone and make a huge opening and actually uncover the actual defect from below. So after having drilled this bone, you can see that defect is really huge, and now I have it head on with my 0 degree. And now you can see, after assessing the bony margin, dissecting on the dura, making it fresh, only after that I'll be putting on the fat with a bath plug technique inside. So I need to make sure that this patient does not come again on my operation table, and this patient has 100% success rate. So do not fear anything. Just drill on the bone on the posterior wall of the frontal sinus, open up the area, expose the area, assess the defect size, make sure you have completely explored the area. Do not leave any secondary site behind. After having done all this, plug the fat, do a bath plug technique, cut the string. As you can see, it's a vicryl, it's an absorbable suture. You can see there is no CSF leak anymore. You can see slight pulsation, but that's quite natural. One more plug of fat, making sure that you have a tough seal inside. Now you can see there's no CSF pouring out. You can see that that's the tissue glue I'm putting in, making sure I keep the frontal sinus patent. Make sure when you put the glue inside, the frontal sinus should be patent enough, as to otherwise it will cause secondary or what do you call that, as mucocele. You can see one more fat plug over this and one more tissue glue layer, and you can see at your 11 and 12 o'clock, that's the frontal sinus opening, quite patent. Make sure even you put the free fascia graft, do not block the frontal sinus. And now you can see that's the secondary site, that's the second side of CSF leak behind, which I'm going to go and explore right now. So already I've done the full house fest. I'm just going to decongest this area. You can see the CSF flowing out very mildly right now. At your 12 o'clock, that's the CSF leak happening, and that's some capillary ooze down there at 6 o'clock. So I'm going to take a ball probe. This is still a 0 degree, and you can see I'm going to go inside and feel for the give away of the resistance, making me sure that the defect is present. You can see my ball probe has gone through and through the skull base. That's the ball probe going through and through the skull base. That is the defect there. So now what I'm going to do is take a 70-degree endoscope, which will give me more superior vision inside. And before I do that, I'm just going to drill that skull base bone a little bit. This is some irregular bone. Now, what you can see, this is a 70-degree endoscope facing upwards. And what I'm trying to show you right now is that skull base. So this area is basically lateral. This is the patient's right side. It is more towards the orbit, that is the lamina superiorly. That's the original site we've repaired. And coming behind, you can see I'm going to pass the ball probe through and through. That's the skull base defect right there. That's a huge defect, and there was a lot of bony fragments. So following the road traffic accident, this patient also had a secondary site of a CSF leak. You can see the pulsations down there, up there, and you can see the multiple bony fragments through the skull base defect. Make sure you remove all these fragments. It should not. That's the arachnoid layer you can see inside with pulsations happening. That's the arachnoid layer inside. So at your 9 o'clock is the orbit, and your 12 o'clock is the skull base. So you can see that's the orbital skull base junction over here, and that is a huge skull base bony defect which you need to plug in with fat. Same technique, bath plug technique, or you can just plug in the fat, half in, half out, or you can say 3/4 in, 1/4 out. Make sure you do not plug a lot of fat, otherwise you're going to have a raised intracranial pressure inside. You can see I'm using a net cell just to keep pressure on the fat and suction at the same time, so that the fat does not get sucked up in the suction machine as such. You can see that's the fat. I'm going to put one more layer of fat, completely plug that area, and as you can see, I've completely taken away the mucosa from that skull base area so as to not form any kind of mucocele or entrapment of secretions. The bone is raw. You can see that's all skull base, that's all brain above. So you can see multiple fat layers up there. and then a layer of net Surgicel to induce fibrosis and extra additional support for that fat. And over this, I'm going to put a layer of tissue glue. Now this is a Surgicel layer over the initial site of the repair, and that's the frontal sinus opening kept patent so that there's no mucocele in the frontal sinus area. Then one more layer of tissue glue just to provide more support. Make sure you do not block the frontal sinus opening as such. Make sure you do not block the sphenoid sinus opening as well, which was open all this time. Now coming back to the 0 degree, you can see I'm taking the Hadad flap right now, which I had not taken initially. I usually prefer to take it towards the end in cases of CSF leak, because I need to know how much of the area I need to close. So you can see that's the Hadad flap I'm taking right now with a incision with 15 degree blade vertical, and then retrograde I'm going to go anterior to posterior with a turbinectomy Caesar. I don't use cautery for my incisions at the Hadad flaps because they tend to shrink the edges. I hate doing that. I love using turbinectomy Caesars and blades for my incisions. You can see there was a superior septectomy done for the window to go for binostril approach. Keeping that in mind, I need to cut the superior and the inferior incisions for my Hadad flap. I can go and cover the entire floor depending on my size of the defect. You can see I'm taking a superior incision right now. So you can tailor the Hadad flap. You can see that's the Hadad flap. I'm trying to elevate that. That's the posterior most aspect of the choana. You can see that's the superior window I had taken for the binostril approach. And carefully dissecting it, that's my superior incision done. And that's my inferior dissection. That's the posterior most area of the sphenoid os. I'm taking the inferior incision with a turbinectomy Caesar right now. And so superior incision, inferior incision, a good amount of thick Hadad flap. And then I'll rotate that Hadad flap. You can see that's the inferior incision, and that's the base of the Hadad towards the choana. Make sure you do not damage the posterior septal artery. You can see very gently I'm trying to elevate that. So I have not included the nasal floor here in the Hadad flap because I did not want my Hadad flap to be that big. So you can see that's my inferior incision complete. And now it's the time to rotate my Hadad flap and lay it on to my primary and secondary CSF site. So you can see I'm now rotating that, making sure I keep the proper layer facing towards the leak site, making sure I do not obstruct the frontal outflow at all. So you can see that's a huge Hadad flap covering the primary and the secondary leak site, making sure also to not obstruct the sphenoid sinus opening. So you can see that's the Hadad flap completely spread out, and that's the frontal sinus opening up there, completely patent. That's the Hadad flap kept very normally over the cribriform plate, olfactory neuron, the primary and the secondary CSF leak site. That is additional support. That is the multiple layers of Abgel that I'm going to keep against that Hadad flap. Multiple Abgel pieces, moderate to large size. You can see the airway is free down there. That's the septum in midline. So at the end of the surgery, there will be no huge septectomy left, and the anatomy of the patient will be also well maintained. Now you can see the entire upper half where I've put the Hadad flap. I've packed it with a lot of Abgel, and then I'm going to inject or just wash it with a lot of normal saline so it swells up. And you can see the lower half I've kept reserved for the net cell packing. So you can see I am doing an endoscopic net cell packing, making sure that the tip of the net cell exactly goes in the choana and nowhere else. A lot of time what happens, surgeons blindly put the net cell inside and that ends up going and hitting on the sphenoid sinus, the base of the head flap, which kind of rotates the head flap again and migrates or displaces the head flap. So I always make sure that I do an endoscopic head placement. Now what I can see over here is the navigation system I'm trying to use while I was trying to do a draft LOTHROPS procedure inside. You can see at the bottom left of the screen, that's me holding the endoscope, and on the patient's right side. So I'm trying to operate. At the same time, I'm trying to show you the use of the navigation system. I'll be showing you the use of the navigation probe. You can see the navigation probe in blue. I'm placing it against the cribriform plate. Now the navigation probe is exactly at the cribriform plate, skull base that is, making sure that I do not enter the brain while I'm drilling on the bone. And now you can see the probe has shifted on to the frontal beak right now. So that's the frontal beak. So I need to differentiate between the frontal beak and the cribriform plate while I drill, hence to prevent an accidental entry into the patient's brain. So this is how I use the navigation probe to easily detect the location for the skull base.